The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hi, TMD warriors. I'm Tony Urbanek, and we're here for the next edition of TMD Demystified. Today's presentation edition is going to focus on the examination necessary to nail down the diagnosis of TMD. Simple, truly simple. I'm going to take you through this a couple different ways. Hopefully it won't take too long to take you through it, because the examination, I just looked at one of my exams, the exam itself, it was 2 minutes. I'm going to show you that examination after I develop it here with you verbally. And actually, I was surprised it was 2 minutes, and I wasn't rushing. And the point is that, again, TMD demystified. There is so much confusion about the diagnosis itself, the problem itself, the thought process out there that this is such a complicated process and a complicated problem. It's just not true. And that is definitely demonstrated by the exam that's necessary to nail down the diagnosis. To take you through the process, and over several of these episodes, I'm going to take you through the entire process of a consultation very carefully, very thoughtfully, and very completely. But the process really starts out at gathering information about symptoms. And that was one of the prior episodes where I went through the symptom list and the symptoms you need to know, whether you check them in or check them off, check them on or check them off, check them positive or check them negative. Symptoms are just red flags. Symptoms give you a direction to look, and as you gather symptoms, the more symptoms that are consistent with the problem, the more indicators there are that that is the diagnosis. But it is not the definitive point where you make the diagnosis. The diagnosis is actually made by a combination of history, symptoms, examination, and then any kind of lab that applies. And in our case, the only lab that you really need for the diagnosis of a TMD, and it isn't even absolutely necessary, and that is a decent X-ray, a Panorex. And you get the Panorex just to make sure you're not missing anything, like a sinus full of gunk, or a cyst or a tumor, something like that. You may or may not see damage to the temporomandibular joint itself, depending on how long they've had the problem, but the Panorex is not diagnostic. The diagnostic point is the examination. That is the point where you can say, yes, this is TMD, or no, it's not. And so I'm going to just take you through the simplicity of the examination, the parts of that examination, and then show you an examination, and then maybe have a couple comments afterwards, but I'll try to take you through what you'll be looking at here very shortly, why those points are important, why those are issues that you need to know about as you do the examination, and the exact point where you can actually tell the patient, yes, this is TMD, or no, it's not. So, and if you've been following me for several of these episodes, you'll know that it's all about inflammation in the joint. If you have inflammation in the temporomandibular joint, that is the diagnosis of TMD. You don't have TMD symptoms, you don't have a TMD diagnosis unless there is inflammation in the temporomandibular joint. So let's take you through the steps of the examination verbally first. When you see this 2-minute presentation, it's going to go so fast you may not even recognize what I'm doing. So I'm going to take you through basically the 5 parts of it. The first thing you want to do is you just have the patient open up as widely as they can and measure their interincisal distance, or IID, documented in the chart. You want to know that because it brings you to an understanding of, are they locked? Do they have a closed lock? Can they open all the way? Don't need to bother yourself with the position of the disc, or listening to the joint itself, hooking up any machines to it. You just want to know how far the patient can open their mouth. And a lot of times they're not going to open to normal range, which is 45 to 55 millimeters. 45 is kind of the lower number on the minimal, and 55, although I've seen people 60, but 45 to 50 is the normal range for IID, males and females. Males a little more. The second point is, after you measure interincisal distance, put your finger in the mouth and look around for tori, palatal tori, lingual tori, and lateral, maxillary, and even mandibular exostoses. Why do you want to do that? Because lingual tori, palatal tori, and exostosis are a surefire proof that patient bruxes. You cannot get lingual tori, palatal tori, lateral exostoses unless they're a bruxer. And again, I can't at this time take you through the physiology of bone physiology, which explains why that is. It's bone physiology, and anybody who wants to look at it, and maybe sometime I'll have a ability to take some time and take you through some pages on a textbook by Enlow, Donald Enlow. I recommend it highly. As far as anything you want to know about facial growth and development of the skeleton, how it grows, why it grows, absolutely iconic textbook. And the more you read it, the more you want to read it. If you're into orthodontics, if you are into understanding why you have different facial growth problems, the basics on it, the basic science on it is all in that textbook by Donald Enlow. I read it the first time 40 years ago. I've read it 2 other times in the meantime. Excellent textbook. So that in that textbook, you'll understand why bone develops in areas of stress, which is what stresses the teeth, bruxism. Okay. The third point is always take your finger and go up the side of the mandible, both right and left side, and touch the tip of the coronoid process. 99% of the time, if they have TMD, the tip of the coronoid process is going to be tender. That's where the temporalis muscle inserts, and that is where the nocioceptors are embedded in the periosteum. And when the temporalis muscle gets tight, it's going to pull on the periosteum, and that point will be very tender. Well, that is an indicator that the muscle is tight. The muscle's in trismus, or whatever you want to call it. And you'll see it extremely often in patients who brux and patients who have TMD, but it is not the definitive point. The next point is to look at the classification of the bite, class 1, class 2, class 3, with emphasis on, is there a significant difference between CO and CR, centric relation, centric occlusion? And that is very important later on down the line as you treat these patients, because as I've mentioned earlier in earlier episodes, a significant difference between CO and CR, in whatever significant means, and that can be defined different range, but a significant difference between CO and CR will actually cause TMD, overload the joint, inflammation, symptoms. So you want to document that, because once you get the patient comfortable, if there is a significant difference between CO and CR, which can be a huge class 3, a huge class 2, or even a couple millimeters, 2 or 3 millimeters, for some people can be enough of a difference. It will overload the joint and cause inflammation. And if there is, then you need to be prepared to either treat that COCR correctly, if you're an orthodontist. If it's a significant difference, like a larger class 2 or class 3, you need to bring an oral and maxillofacial surgeon into it with orthognathic surgery and orthodontics. Some cases that aren't too large can be addressed with occlusal dynamic reconstruction of one kind or another. But don't do that in place of appropriate orthodontic, orthognathic treatment when it's necessary. I mean, our technology is tremendous since I initially trained 40 some years ago, and actually helping people and getting people into proper occlusion, proper function, proper facial profile and proportions. And I know you all know what I'm talking about. So don't be afraid to tell your patient if they have a big class 2 or class 3, or they have a functional malocclusion that can be fixed, it should be fixed. And sometimes it's going to take surgery. And as a maxillofacial surgeon, I'm very aware of how many doctors are afraid to do that, which is a shame for the patient's point of view. If they don't want to do it, if the patient doesn't want to do it, that's fine. At least they are aware. So many patients I've seen over the years have absolutely not been aware that there is a solution for the problem that they're aware of. They know, and they know how it looks, and they know the problems they have with chewing. And they've been to 5 different dentists, and no one has had the guts to just tell them, I think there's a solution for this, and I have a couple associate colleagues that I think know how to treat this thing. All right, enough about that. But the point is, that is critical to classify the occlusion and specifically look for COCR problems and be able to identify that for the patient and tell them when appropriate that it needs to get fixed, gets handled. And then the gold standard is to do the examination of the joint itself. And it takes 30 seconds. And basically this is what you're going to see, and that is, first of all, stand beside or behind the patient. And first of all, show them what pressure on your fingertips feels like on the side of the head, so they understand what pressure feels like. And then instruct them on what they need to do, which is open widely to the maximum opening that they can, whatever it is. As they do that, your fingers will slip down within the glenoid fossa as the condyle exits the glenoid fossa. And then instruct the patient to open widely. And I'm going to put pressure in. And then I want you to bite together quickly. Just close your mouth on your back teeth like you normally do, but as quick as you can. No chewing, none of this. Just bite together. Boom, close. Make sure they understand the instructions, because believe me, if you do this enough times, many patients just hard time following that along, and they'll give you something different. But that's all you need. Open widely, put the pressure on, and have them bite together as rapidly as they can. If that hurts, they have inflammation in the joint. If they have inflammation in the joint, they have TMD. Now, one other caveat about this is that when you do enough of these, you will find that males have frequently a different response than the females. And that is because it's 95% females, 5% males, and it's 95% females because estrogen exacerbates inflammation. But there may be more to it. I am not sure, but I can tell you that many males, when you do that, they're going to say, no, it doesn't hurt. It feels tight. And you can occasionally, have a female say that also. 98% will say it hurts, pain. If there's inflammation there, it hurts. And some people, for reasons that I don't understand, will not register that inflammation like everybody else. And they will talk more about tightness. And the males, you will hear more about tightness when you ask them about their symptoms. Do you have or have you ever had frequent or recurring headaches? I go, no, but I got this tightness. A lot can be studied or, done about that, trying to figure that one out, but don't know. So that is the examination. And if they say it hurts, then you document how much it hurts, their subjective degree at which how much it hurts. on a scale of 1 to 10, how much does it hurt on each side? And they will give you a number. Some people have a little hard time giving you a number, but they'll give you a number between 1 and 10. Just document it in your chart so you know basically at that point in time, it can switch side to side what percentage of the pain is coming from which side. And again, these symptoms switch sides and they switch positions on the face and the jaw and the neck and the upper shoulder girdle all the time. So you're never going to have consistent examination. Although I can say, once you treat the patient appropriately with the device and protocol, and the inflammation goes down, and they tell you subjectively that 85 to 100% of their symptoms are gone, when you do this, it doesn't hurt anymore. Fact, which just proves the point. I mean, it's a significant diagnostic tool to tell you whether the joint's inflamed, which tells you whether they have inflammation in the joint and TMD. So that's the examination. That is a long-winded way to explain 2 minutes of an examination. The rest of the stuff that you see, hear, been taught, as far as I'm concerned, is extraneous, not important. It's just not important. Why do you want to go through all these other non-significant examinations, especially examinations that cost a significant amount of money, like MRIs and CT scans that don't prove anything? An MRI or CT scan has never, ever helped me make the diagnosis of TMD. It can show you details in the joint, but who cares if you make the inflammation go away and you can diagnose it adequately, significantly, predictably with a very simple examination. So I'm going to stop right now and we will go to that 2-minute examination. We'll flash it up there. And then I'll come back and have a few closing remarks.
See if we can figure this out, okay? All right. First thing we're going to do is just going to see how far you can get your mouth open. Open as wide as you can, even if it hurts. I'm not going to push. You just open as wide as you can. Push, 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 push. Thank you very much. You're open to 45 millimeters, which is about normal, actually. Did it cause any pain to open that wide?
Yes.
Okay. Open up really big as best you can. I just want to look around here a bit. I'm going to touch something. It's going to be tender probably, right there. Is that tender when I touch that?
Yes.
Open up really big, 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 big. How about this side? Is this tender up there?
More tender right here.
All right, Andrew, we're going to do one more thing, okay?
Okay.
We're going to put some pressure on these jaw joints. Now, this part might hurt, and I apologize if it does, but we got to do this, okay? Just going to put some pressure, okay?
Okay.
But first, I'm going to show you what pressure feels like. With my fingertips, that's a lot of pressure, okay? And what I'm going to do is I'm going to get my fingers in the right place. Then I'm going to ask you to open widely.
Okay.
Then I'm going to put the pressure on. Then I'm going to say, bite on your back teeth quickly. Don't bite till I tell you to. But when you close your mouth, all I want you to do is close your mouth on your back teeth like you normally do as rapidly as possible, okay?
Okay. Yes, sir.
When you do that, what I want to know is it cause any pain rather than pressure, okay?
Okay.
Open up really big for me, really wide, big, 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 big. A lot of pressure. Bite together quickly.
Oh, yeah.
Does that hurt on one or both sides?
Mainly the right side.
How do you grade the pain on the right? 1 to 10, 10 being the worst.
I mean, it's more like maybe a 6.
Left side, 1 to 10, 10 being the worst.
Probably like a 2 or 3.
Okay.
All right, so you viewed the 2-minute examination. Don't hesitate to run it through again if you have any questions. Obviously, you do not have to do it like I do it. You can do it, doctor, you can do it any way you like. But I show that because, time is of the essence when you are running a busy practice. And although you want to spend appropriate time with the patient, make sure you nail down the diagnosis, you don't want to spend a lot of extra time with all this. And I certainly don't. After doing we've treated successfully well over 3,000 patients right now. So I guess I've probably done 4,000 or 5,000, probably like 4,000 or 5,000 examinations, because not everybody gets the device. And over those 5,000 examinations, I've really honed down the critical issues, the critical method, the important things that you need to know. And disregarded all of the things that are just not important. You certainly don't need any machines hooked up to the patient. And you don't need MRIs and CT scans. That's a waste of somebody's money. And basically, if it's the insurance companies, it's basically your money because you're paying for the insurance, whether it be public or private. So one other feature about this examination I'm going to show you, and that is we've produced, our company has produced a brief video with a professional person model doing this examination for public exposure presentation, whether it be for your practice or a meeting. And I'm going to place that here also. You can review that. Again, it's a very brief video which shows public how to do self-examination. It's all about self-examination, where a patient who have symptoms that they can't figure out or their doctors can't figure out can do a self-examination. And if their joints hurt, they know the joints are inflamed, at which point then they can seek out appropriate and effective care. So I will show that at the end, and I will hope to see you for the next edition of TMD Demystified. As to next time, we will cover some of the explanation and process that I take the patient through in educating them so they understand about the problem they have. This is very, very important. This is very critical to the entire consultation process. It builds confidence. It builds understanding. When you do both of those things and the patient actually understands their own problem, they will follow through with treatment if they can afford it. That is the fact. They always follow through because now they understand what's going on. Their skepticism is significantly decreased, and what they want is make their symptoms go away. So thanks for your attention. I look forward to speaking with you next time. I wish you a successful week, and I'll talk to you soon. Bye-bye.
Steps to a self-exam. Step number 1. Place your fingers of both hands in front of your ears where the TMJ is located. You should be able to feel a depression in front of the ear as you open your mouth widely. Step number 2. Open your mouth as wide as possible. You should be able to feel the depression when you open your mouth. Press firmly into the depression, equally on both sides. Step number 3. Close your mouth rapidly. If you feel pain on one or both sides, it is highly likely you have TMD, temporomandibular joint disorder.